Hello Malaysia and welcome to another edition of Medical Today, Season 3.0, Episode 2. I'm Jared Ratnam, and on the show today we're taking a look at a few things. We're going to take a look at healthcare in Malaysia shortly, and also an acronym, IVF, or in vitro fertilization. What is all this? We're going to shed light as to what happens with regards to technology and IVF in Malaysia. Towards the end of the show, though, we have a fantastic video for you, and we have a prize that we're going to be giving away. We'll give you more details as we move along right here in Episode 2, Season 3.0 of Medical Today. But to start off things today, we've got Dr. Gana Baskaran Nadason, President of the Malaysian Medical Association, joining us to give us more of an insight as to what the MMA is and how the medical fraternity in Malaysia is faring at this point and how we're going to move forward. Doctor, thank you very much for joining us. It's a pleasure and an honor to have you on the show. A lot to talk about with regards to the medical fraternity in Malaysia. Now, you're with the MMA, you're the president of the MMA. What are your objectives and goals at this point and the plans you have for the MMA?
Gerald, good afternoon. Thank you for inviting me. Malaysian Medical Association is one of the oldest associations in Malaysia. We have been existing for the last 60 years. Mm-hmm. We have played a very definite role, not only in the taking care of the welfare of our medical doctors and professional medical fraternity, but we have done quite a bit working with the government of the day. You know, our belief has been that the Ministry of Health, as being the provider, for nationwide provider, we have worked with them very closely in ensuring there is a fair delivery of healthcare system in Malaysia.
How do you do that?
Well, most of the time when Ministry of Health has got their own objectives and directions, we generally give them the input from the ground. You know, we are the frontliners. As you know, the primary care GPs in the country have played a definite role for the last 70 years. And we have been getting all the feedback, and whenever they need us to give them the feedback and information they need from the ground, we generally give it to them. And it's FOC, we don't charge anything to the Ministry of Health for doing such a thing. Because we want to make sure that the Malaysian population is healthy, and we want to be part of that system. And that's what we've been doing for the last many years.
Right, so to go back to what you're saying just now, the primary goal or goals set by the MMA is, very simply?
Objectives are very simple. We want a total, overall, good healthcare system in Malaysia, with the view that our members will provide the services at a very affordable cost to the public, general public in the country.
Right. It's interesting you talk about general public, because when we talk about general public, there's always opinions about, especially the public healthcare. Now, if someone goes there and gets medication worth 500 ringgit for free, everyone's like, oh, we've got a great system. But if you have to go to the hospital and wait for 2.5 hours, then they'll come back and say, God, I hope we can do something about the system. The system is horrible, so on and so forth. And you've heard all of this before. Now, do you think we have a problem, or do you think we've moved forward from where we were 20 years ago?
Well, if you ask me, really, a lot of improvements have been done. I mean, the hospitals have improved. There are a lot of new hospitals, new health clinics in the country and all that. But let's not forget, as long as there is free service, Malaysia is proud in the sense we are always proud to say we are one of the best healthcare systems. It's not said by us, it's said by WHO. We have a very good system, but how long can it last? The services can only be improved if there is a national health insurance scheme where everybody has got a role to play and contribute.
Well, if you talk about national health insurance scheme, there's the NHS in the UK.
Yeah.
But with the NHS, it has its pros and cons too. So if we're going to start something here, we must take into consideration that it's only going to be done for 30 million people. Now, the way we make it sound like it's such a tough job simply because there's a lot of technicalities to look into. But for a population of 30 million, do you think that's a problem?
I don't think it's a problem at all. I think we have been talking about it for the last 20 over years. The National Health Insurance Scheme has been spoken about, discussed. So many research work has been done and all that. All it needs is for us to sit down, especially the politicians, to take the right decision. Mm-hmm. They must be firm. And all of us, the stakeholders, must be consulted.
Right. Can you speak in my good ear? You said whom? Politicians.
Okay. It's a political will. I mean, they must make the decision, because you can't be postponing a decision like that. Mm-hmm. No government in the world can go on affording to give this kind of free service.
Right.
And when something is given free to you, Gerald, you should know that people don't really take it well. Even the medicine, when the hospital was giving free medicine, a lot of them go and collect medicine, and after that they don't even use it. They just throw away, or they just dispense it to other people who don't need the medicine. And many of the time, only now recently, because of the restriction in the type of funding that we have now, in Malaysia after the last election, a lot of funding has gone down. So now they are restricting supply of medicine. People are becoming more cautious and very conscious about using them right now.
Right. I think there should be awareness, both with regards to what the system is and how we use the system. Like you said, you rightly pointed out that most of us go there, we get all these medications for free, and we're really happy, but we come back and we chuck them in the bin. Yeah. Now, we need to understand that these medications are being paid for, and they need to be used if it's prescribed to you. And if it's not, you shouldn't take them. Now, I think the other question that comes up here is sustainability within Malaysia. Now, you see the overcrowding of hospitals, public clinics and hospitals especially. How do you think we can circumvent this problem, or how do you think we can work through this problem and better the system? Of course, I shouldn't be giving opinions here, but I sincerely feel that there should be a volunteer program. We've got people who are leaving the workforce, okay? People in the 50s, in their 60s, but people who can still go to hospitals, spend an hour or a couple of hours a week helping, just guide people around. I seriously think that will make the system better. Do you believe so?
I think, Gerald, the world has changed. You must understand. Mm-hmm. First of all, the delivery system in this country, the primary care physician like us, 7,500 are well distributed all over Malaysia. Mm-hmm. These primary care physicians are given a definite role to play. For example, outsourcing of NCDs, non-communicable diseases.
Yeah.
That takes away about 50 to 60% of the entire disease in this country. Mm-hmm. So if you are outsourcing that to the primary care physician, we are ready players, mm-hmm. and we are not going to be overcharging. You must understand, Gerald, before the advent of the private hospitals in this country, it was the GPs who played the major role.
Yeah,
we were not only just your physician, we are friends,
Yeah, but I guess that landscape has changed, and I know, and I've spoken to the Minister of Health, and he believes that he wants to bring forward the primary health care. He wants to strengthen that or solidify that more than anything else at this point, because that is a very important front. Now, I think there is a problem here, and correct me if I'm wrong, that insurance companies have somehow taken over that role.
Well, definitely. Now, like they say those days, don't leave home without American Express. Now you don't leave home without a medical insurance card. Because, the moment you walk mm-hmm. into the hospitals, when you see you with a medical insurance card, everybody is very happy. Mm-hmm. Whereas our doctors, GPs, let me tell you, I think the entire system, first of all, let me thank the minister. Honestly, I believe he's very sincere in helping us. Mm-hmm. He wants to help us. We have many discussions with him. I think he's looking at the right things to be done. Meanwhile, what has happened with us is we have been neglected. Mm-hmm. Consultation must be all the time ongoing. Mm-hmm. Without a consultation, if you go and set up a program, mm-hmm. and then later you decide, hey, there are some shortfalls in the program, we can't do anything much to help you. Mm-hmm. This is a problem in insurance companies. Formerly, people used to pay their own money. Now, in our clinics, 70% of the patients are from TPS and MCOs, referred by employers and employees. only 30% is out-of-pocket expense, I mean OPP. The people who are coming there. So 70% of the market now is controlled by the third-party administrators and managed care organizations.
Right. So how do we work around this?
Well, we have been having a lot of discussion. We see, there are a lot of companies we believe by you employing this TPS and MCOs, they will get a better way of sending the employees for treatment, maybe cost factor and all that. But don't forget, like us, we are regulated very strongly. The GPs in the country, medical professional hospitals are regulated under the Private Health Facility Services Act. Whereas the TPS and MCOs, though they form part of the Act, they are not regulated. There's no regulation for them. So they determine the current market price.
Right.
And this dichotomy was created not by the doctors. It so happened in the world, many countries deregulate the medical fees. But in this country, somehow or other, we are regulated by the medical fees under this act that was...
I think there's a problem with that. There's also a problem now, this is not my script, but I'm going to bring it up anyhow. Dispensing separation, what are your thoughts on it?
Well, dispensing separation, be very frank with you, it is not possible at this point of time. It is not because we are not ready to, but the thing is, unless the fee schedule, which is now going through various stages, which has been going on, Gerald, you must understand, Gerald, we are not money suckers. 27 years, our fee has not been changed. We are regulated strongly by the fee schedule, we follow it. But despite that, you must understand, in this country, it's a bundle system. Though we get a fee schedule approved, say, 30 ringgit or whatever ringgit, but we can never do this to our patient because my patients have been with me for many years. We want the schedule because there are certain reasons for that we are asking this fee schedule to be harmonized. When it was approved in 2013, there are two fee schedules, Gerald, you must understand. One is called Fee Schedule 7, which is essentially for the primary care GPs. The other Fee Schedule 13 is primary for private hospitals.
Fee Schedule 7 and Fee Schedule 13. Okay.
So Fee Schedule 13 is primarily for the private hospital. But in the private hospital, you don't forget there's an emergency department with GPs working. So in 2013, what happened, we don't know. After so many years of discussion for 19 years, somehow or other, our MOH friends, not because they may have done, I don't think they would have done it wantonly, they got Schedule 13 approved. Schedule 7 was forgotten. So when we realized, when we saw that the Schedule 13 had contained emergency GP doctors in private hospital, their fee was given to 30 ringgit to 120 ringgit.
Right.
Whereas our fee was between 10 and 30 ringgit for 19 years. So when we saw that, we thought, oh my God, at least the fee schedule has been approved in Fee Schedule 13, we can also use the Fee Schedule 13. But when we started using that figure, the TPS and MCOs came back and told us, oh, my brother, this is not for you. This is only for the private hospital, the GPs. You need to wait for your fee schedule to be harmonized.
So we're back at one.
Back again, it's back at square one, definitely. We have done everything possible under the sun to go and meet all the various agency departments and all that. Now, last year when they came in, now they put us through the town hall meeting we had. Even the consumer groups are very happy. They said, we deserve to get an increase. Now we have gone to Majlis Tindakan Sara Hidup, Kos Sara Hidupan. That is a national NACOL, your national cost of living. So we have gone through one round with the Ministry of Health. We are doing another round with the Minister of Consumer Affairs. And finally, I'm told it's being chaired, the national one will be chaired by our Deputy Prime Minister, none other than our own medical colleague, Dr. Datin, Yahama Brahma Datin Wan Aziza will be sitting there.
Right, right. So we've got about 5 minutes left. Very quickly, I want to move into technology. In the world of medicine in Malaysia, things are moving pretty rapidly. So, which means you see a lot of technological changes within the way medicine is given to the people, how it's dished out to the people. What are your thoughts on technology and trends in Malaysia?
No, Gerald, one thing we must remember, the only thing permanent in life is always change. Change is the only thing permanent. So anything that's innovative, anything that can make it easier for our patients in delivering the system, not only medication, in terms of consultation and all that. Telemedicine is here to stay. Nobody can run away from telemedicine. The government actually launched this telemedicine in 1997. Over the years, they've been...
Yeah, but while you're talking about telemedicine, I think the other thing to look at is to go back to primary healthcare, like you're saying. Now, when a physician checks a patient for the first time, there's certain things a physician needs to do that a lot of people say is being lost, that it's a forgotten art. Now, I've spoken to doctors who've been practicing for a good 30, 40 years. I just interviewed a doctor in my town who's been practicing from 1986. And he said people just forgot general checking, just the general well-being of people. You need to talk to people and find out what their problems are in order to make that journey into their lives and find out more about their medical health problems. Do you think that is a problem with younger doctors?
No. Young doctors are more innovative than the senior doctors like me. I started practice in 80. Now I become a locum doctor. I don't go full time, but still, the younger doctors are more innovative. But please understand, the primary care physician believe in the personal touch. You know, there was a time that if we don't touch a person, we don't even do a stethoscope examination, though we do a BP, we are considered as not good. How does the name comes to being good doctors? Because they say the personal touch, the personal relationship. But now, you must not forget that a lot of new diseases have come over the years. New diseases. If I'm sitting in a clinic and I'm examining you, if I want to follow you through and through, I may be lost at some point. So I need to contact another specialist. I can't ask my friend, if let's say I'm from Johor Bahru, I can't be referring him to Kuala Lumpur. If I have this telemedicine and telehealth, it's easy for me to communicate. I can pass on the information. I can even tell the person what, because saving time, saving cost, and secondly, saving his life. That's more important.
Right. So most of us are under the impression that when you go to a doctor, this doctor gives better medicine than that doctor. He's got more powerful medicine. But that, I think what needs to come about is more education. Now, before I let you go, what's your advice to us about understanding and learning about or being aware about the medical fraternity, about health and about healthcare?
First of all, let me say, we GPs have always been in the front line, primary physician, even the consultant and specialist. We are here to help you. But don't forget, doctors are that much as when you believe in, always when you come to the hospital, you see the doctors, you say, hey, doc, you are my God. Yeah. After we have finished all the treatment, you say you're God. But after that, we also hold your hand and say, there is one above you. So what we are saying is, you need to look after your health. Public cannot be just thinking doctors are all there to do everything. You don't plan your life. You don't look after your own health in the terms of, good exercise, good diet, good living, then you won't not be able to. And sustaining nowadays healthcare.
But how can you impress this upon a society which predominantly is a working class society? Most of us living in middle Malaysia, we'll read and all that, get books, journals, read the Lancet, probably do some Googling and understand. But the working class, how do we bring this to them to tell them that lifestyle changes are important more than anything else?
Gerald, you and I know, 20, 30 years ago, we lived in a rural situation when people didn't know anything. There was only 3 television. Now you got so many. Burnama does this weekly. Every television speaks on it. And everything does it well. But unfortunately, people don't want to learn the good things. They look at example, Percaso, Soxo, I can tell you. In 2013, they floated this idea of doing HSP vouchers. I don't know whether you are a Soxo. I don't think you are a Soxo contributor.
I don't know. I'm praying now that I have some sort of coverage. We don't know.
But they gave millions of vouchers free to the workers. Do you know how many million of vouchers are lying down there? 2.3 million vouchers had not been even touched.
No, haven't been touched.
And what is that? If the government can go out of the way to do this, if you don't want to learn it, but all other issues, you can tax people about this. One person doing something there, immediately the whole country knows about it. But when you come to learning good things about health, everybody says, I don't know. When did the government do this? Pakka 40, My Salam, all these are for people. But sometimes technology has advanced so fast, there's sometimes ordinary person using. But don't forget, there is a Mr. Google now. If you don't know about using Mr. Google, you can ask your children to Google. They will tell you all from diagnosis to preventive, from curative, and the medication is given to you. So whenever a person comes to me nowadays, I must be very careful because he knows better than me.
Right. Dr. Gana, thank you very much for joining us. It certainly was a very interesting conversation. We just spoke to Dr. Gana Baskaran Nadason, President of the Malaysian Medical Association, right here on Medical Today, Episode 2, Season 3. We'll take a short break and come back with more for you right here on today's edition or episode of Medical Today. Stay with us.
Thank you.
Thank you. Hello and welcome back to Medical Today, Season 3.0. This is Episode 2. My name is Gerard Ratnam, and from speaking about the Medical Association or the MMA in Malaysia and understanding where they're coming from, it's time for us to focus on something else. Well, on the show today, we want to feature IVF. Everyone knows what it is, in vitro fertilization. Now it's become a big buzzword in Malaysia, and of course that comes with its own set of problems, and we're going to try to find out why Malaysians are opting for this. Joining me is Dr. Mohan Varutha Rajoo. He's a fertility consultant, obstetrician and gynecologist from KPJ Damansara Specialist Hospital. Also joining us is Darlene Ernie, and we'll find out why she's here in a short while. In the meantime, welcome to the show, both of you. Thank you very much for taking time off to be with us. Doctor, there's so much to understand about IVF. Now, we know it's an acronym for in vitro fertilization. Now, before we get into that, let's talk about your work as a fertility consultant. Obstetrician and gynecologist, most of us are pretty clear as to what they do. But when you say fertility, with the addition of fertility, how does that enhance your specialization?
If fertility means, fertility consultant means where we see most of the patients who are unable to conceive. That is where after their marriage more than a year. Okay. Let's say you're married more than a year, you're unable to conceive a child. If you're less than 35 years old, you need to seek treatment for your future child. So unable to do so, so you need to see a fertility consultant.
Right.
But in case for the women who are more than 35 years old, okay, if you are married for 6 months and you're unable to conceive, okay, we do advise them to seek treatment much more earlier, rather than you wait for a year or 2 years. So that's where the fertility consultant plays a role, or they come in for the advice.
But I guess before we even get into the thick of things, what got you interested in becoming a gynecologist and obstetrician and then specializing in fertilization?
First you have to be a gynecologist. Of course you have to do
that's the base.
Yeah, that's the base of
isn't
gynecologist. Then further on you need to move on to your fertility studies or fertility field of training. What interested me is, a patient, satisfied or they are happy after the treatment. It is something like, they are longing for, for a child for many years. So once they get the child, the expression, over the face, how they thank you, we feel very happy for that.
I think it brings you joy to see a family bring a new life to the world. Yeah, so that's what got you into it, and that's been your motivational factor. Now, before we get into Darlene, we'll just talk about what is or why is the fertility rate declining in Malaysia?
So why it is declining is mostly due to urbanization, due to the culture shift, due to the more education, and the other thing is because women nowadays they're more educated. Okay, so they are chasing after their careers, or they want to become more in their life, so they delay their pregnancies. So not only that, most of them they wanted to delay their pregnancies and also they delay the number of the children, and they want to give a better education for the children and also to improve the quality of life. So that's why the reason why the fertility rate is becoming declining or less in Malaysia.
Right. So I guess the Asian problem is for us to go and talk to a doctor about this, to talk about fertility problems. Are we changing, or have we changed, from when we first started fertilization within Malaysia? People were shy to talk about it then.
I still believe there are still number of people are very shy to talk about it. I do have patients who come to me after 10 years of marriage. They are very shy. They first of all, I'm not sure why they are shy. I'm not sure why they do not want to seek for fertility treatment, or are they are not aware of such treatments available in our country. And the other thing is, no, they are very taboo. Is it this fertility is going to, harm future of my child? Are they going to be a abnormal child going to be born? But most of them, they think that fertility is something, like in vitro fertilization you're doing outside the uterus. So does it harm the baby, or is it the baby going to be abnormal?
Right. So in Malaysia alone, there's a lot of questions surrounding it. No, is it safe? Is it halal? Is it no? This
it is safe.
It is definitely safe. It's now a lot of papers have been published with regards to that. Now, I guess the next person we want to bring into the conversation, she's been sitting in the between us, listening to the both of us. Darlene, welcome to the show. So, why is Darlene here? Maybe you can explain to us why Darlene is here first.
Darlene is one of our patient, which is she's preparing herself for fertility.
Okay,
so maybe she can give an advice.
So when you say preparing yourself, how do you mean when you say I'm preparing myself? What are you doing to prepare yourself?
I've been married for 11 years now.
11 years,
and I know about. First of all, I know about Dr. Mohan. He's very famous doctor even before I met him.
Right.
So I read a lot about
He's
article.
a rock star in the IVF.
It's true. I know. Just imagine, I know about him like few
just doing
years
our
before
job.
before I met him.
Okay.
So I do the study about this.
Research lah.
Research,
you went back, you did your research all.
About IVF, and at the end I went to go to see his patient, which successful in this, and he has 4 of them that I knew.
Okay, so when you went and saw his patients, the successful patients, what did they tell you? Doctor ni bagus.
No, they say, I was like, is it your first time? Then all of them say yes. I was like, wow, amazing, because some of them, they go up to 3 or 4 times.
Okay.
And they are successful with the first IVF. So I called him. I say, Doctor, I want to see you.
So she says they are successful with the first IVF, which simply means there were cases where people
a lot. IVF, everybody knows it's hard to be successful on the first one. It's really hard.
Right.
Many people just spend and I know why. After I met him, I said, Doctor, I want to see you. So he said, come to this. He gave the address of his office. And then I start to understand why to be honest, he is a doctor that don't do this IVF for the sake of business and money.
Okay.
He really don't do that because I say, I'm ready.
As we've ascertained in the beginning of the show, he does it because he loves it and he sees, it brings him joy to see another life come to the world.
I guess so. Then I went to see him. He said, why are you here? I say, I want to do IVF. Are you ready? I say, yeah, I'm very ready for a long time.
Right.
And then he said, after my treatment.
Did you speak to your husband about this, or your husband?
No, I went alone.
Both of them came together.
And then after that, I go with my husband. So I was surprised that he say, you have to get ready to do this. I say, I am all ready for that time.
Right.
Like
mentally, you were ready.
Definitely. And then he say, no, girls, you're not ready. You have to do this.
No, girl, you're not ready yet. Okay, yeah.
So it is not the the first initial visit when you see the doctor. We don't start the treatment immediately. We need to advise them. Need to prepare them. Need to mentally, physically, their body and everything for the treatment.
Okay, this one in my mind it looks like Rocky preparing for a fight.
It's
like that. So how do you do that? What's the preparation process or the prep process for this?
Okay, initially when they come, we do some blood investigation first, to see whether the hormones are stable. Some of them, they might have irregular menses, or the menses is normal, so we need to see the hormone. Then we do a simple ultrasound scan to see whether there is any mass or what is the size of the follicle, that means the egg which we're going to collect. Not only that, we do advise them on their diet, because diet plays an important role here.
Exercise.
Exercise also. You're right. Exercise also one of the things.
But while you're doing the blood work for the woman, you're doing the relevant scans to see what the situation is. Do you also investigate the husband?
Yes, of course, husband
Uh-huh.
need to investigate. Husband's role is definitely only one role where he need to give his semen analysis, finish his job. Not only that, okay. Only the thing the women.
It's so unlucky that the boys have the easy work. Okay. So what research has been done? Before I get to you, what research has been done with regards to what multivitamins to take to become fertile?
Fertile, you see, there is no such vitamins that I tell you that, okay, we take this vitamin, you can get pregnant. No. Okay. Why we are taking this multivitamin is to maintain our body's health or to reduce the toxins in our body. As you know that as our age advances, there's a lot of toxins in our body. So these toxins are which causes reducing the quality of the egg. So what we do advise them to take this vitamin so that quality of the egg is better.
So this is a natural way of boosting your
fertility. It can be a natural way.
It can be in a natural way, and it can be in IVF.
Okay, so it can be the natural way, it can be IVF. So you have to make that call. Now, before we get back to you, doctor, let's come back to Darlene and find out your preparation process. So mentally you have to focus, you have to be prepared with your husband too, and physiologically your body.
Okay.
How do you prepare it?
I try to, like doctor asked me not to put so much makeup, except for today.
Oh, okay.
Okay.
Chemicals.
No chemical,
Chemicals
and I'll stay away from the ash, and always positive.
See, we thought it was an old wives' tale, okay, not to use too much makeup. Today we know you shouldn't.
Anything we put on our skin is a chemical, so get away from that. And then I feel a lot better after I met him with the diet he asked me to take every day. What the fruit, the everything. Listen to him. I feel like someone new. That it's something that mommy should do to have a baby, to welcome a baby.
So a lot of women don't prep themselves for it.
It's true, it's true.
So most of the time when they come, I'm guessing, when women come and speak to you, you're talking to them about what do you do on a daily basis, after you come back from work, what do you do in order to prep yourself to want to become a mother or to try to conceive? Do you ask them questions like that?
I do, but you see most of the women, they work late night. Okay, when they come, the diet is imbalanced, so they take late night food.
Okay, so firstly, the circadian rhythm is out. Okay. Then the late night food doesn't help.
It doesn't help in anything. And the other thing is, of course, mentally they'll be very stressed out. Okay, so they'll be tired. So there is is a sexual intercourse during that time. So you're working toward the day and you come, you'll be very tired. So that timing of your sexual intercourse, it is gone. So that can be one of the reasons why you cannot get conceived naturally.
It's hard.
It's hard. Quite difficult. Both of them will be tired.
Right. So which brings me to the next question, talking about a fertility window period. Okay. What's this all about?
Fertility window period is the period during the menses time where the patient able to get conceived. So it is ideally will be 14 days before your end of the menses.
Right.
Assuming the women have a menses 28 days. Okay. Most of them, they have a regular menses within 28 to 30 days. So if they have a menses 28 days, so 14 days before the end of the menses, that is day 14, is their fertile period. That means it can be...
Day 14 is when fertility sets in.
Fertility sets in, that means that is the ovulation day. So that means it can be not necessary on the day 14. It can be on the day 12, 13, 14 or 15. So there's a range. So it can be from 12 to 15 days. So this is what we call fertile period or ovulation time. And if let's say you have your menses 35 days, so it'll be day minus 14. So it'll be 120. So my maths is per okay, 21 days. So it can be from 19 to 22 days. So this is a fertile period. But this goes for the women who have a regular menses. How about people or menses for the women who have irregular? That means some of them, they have irregular menses 35, 48 days up to 60 days.
So what you're saying in turn is when you have irregular menses, chances of you to conceive is hard because you don't know when the fertile period is.
Irregular menses hard.
Yeah.
For the regular menses is easy because every month they have their menses 20 days or 30 days. So they can count when is their fertile period. If they have irregular menses, that is 2 months once, that is 48 days or 60 days. It's very difficult to count their fertile period. So it's very simple how you do count is assuming a patient where she have a menses 38 days to 60 days. Okay, so you take the shortest cycle, which is 38 days, you need to minus with 18. So we are getting 20
days.
Then the 60 days minus with 11. So it will be 41. Am I right? So your fertile period will be 20 to 41.
Right.
You don't know when is that. So it is quite difficult for you have a sexual intercourse 2 to 3 days to get the fertile window period.
Okay, so with Darlene's problem, if you don't mind, we dig a little deeper into your problem to find out now, where is Darlene at this point? Coming to you for IVF treatment and opting for IVF treatment, in what stage is she at this point? Because I want to go into another subject. They say you can change the color of the baby's eyes, you can choose the gender, you can, there's so many things that can be done. So we need to move into what is fact and what is myth. Yeah. So where do we start? Can you choose the baby's gender?
Yeah, of course.
Yeah.
Yes.
Yeah.
Did you choose your baby's gender?
No,
you didn't choose. You leave it. You leave it to the Lord. Yeah.
Yeah.
What else can you choose and can't you choose?
Gender is one. The other thing is the abnormality of the baby. As you know, when they age at once, the baby tend to have some abnormal, like, commonly it's kind of Down syndrome. Because as they age at once, baby have to be a syndromic baby. So we can choose to be a normal baby rather than have a syndromic baby through this IVF.
So you can choose, you can opt to have a normal baby. I mean, people won't opt to have a syndromic baby.
Yes.
But having said that too, they say now they can even omit hereditary diseases.
Yes, you're right. We can do that. Yes,
that
from the IVF it is possible.
Okay.
But what we do is we do a pre-genetic screening or pre-genetic diagnostic to choose this syndromic baby or the normal baby.
So you have a lot of boxes to tick, what you want, what you don't want.
Yes.
Yes.
No, but I don't
But
choose
usually,
yeah.
you see, when the couple comes to us, okay, they wanted to have a baby, so they don't mind in having a girl or a boy, so
It's
they don't
true.
choose
As long
unless
as we have
as long as a
one.
healthy
Yeah.
baby.
Yeah. I mean, after waiting for so many years, in your case, 10 years, you really don't care,
male or female.
it's
Yeah.
male or female. All you want is a child to care for. Yeah?
The healthy one.
Now, with that, also while you carry out the process of IVF, you walk them through every step, right?
Yes,
So
you're
what
right.
kind of advice are you giving at this point?
Okay, prior to the IVF, of course, one, you should be mentally stable. One, okay, you should stress-free.
Right.
You
Are you
cannot be
mentally stable?
stressed. Of course, when they're starting, they be stressed up. Okay,
Yeah,
is it going to be a successful or one? That is the first thing. Most of my patients, before start itself, they will ask, doctor,
Right.
what is the percentage successful? Is it going to be a successful one? Or what is the failure rate? All this is going to be stressed up your treatment. Okay, that is important. And the other thing, if Darlene want to explain, how the process, how the injection has been done.
Right. Okay. You want to talk about the injection? Don't scare me, please. I don't want to.
So how many
I don't
days you
want to
take the
fall in
injection,
faint,
and she
okay?
can explain to you.
Okay, I took the blood test at the
Right.
first
Yeah.
day, and then he saw anything we want to do about IVF, it has to be the blood test first. So
Okay,
I
so
found out many things there is less in my body to conceive a baby. So doctor start to scan. We go for the scan, the next treatment, and then I start to have some meds that I have to inject on my tummy twice a day.
Yeah, twice a day.
Twice
That
a
is
day.
one to make the
Two
egg to grow.
different-
Right.
to have a better egg for me. And from what I have problem on my ovary, which it cannot produce many eggs, and after the injection we try to scan, and it's really like
I mean,
A
you're
lot.
seeing
Yeah,
a good
it's
success
really-
rate.
Yeah.
Yeah,
The purpose of
yes.
this injection is to make the how many of numbers of egg
Yeah.
to grow, as many of the eggs to grow,
Right.
so that once the eggs have grown to the size that which we want, where we call it a maturity, which is around 17 to 18 then we try to retrieve the egg. The way how we retrieve the egg is by giving the sedation, where patient will be knocked out, so you don't feel the pain and everything.
It's no pain.
Yeah.
Actually, it's no pain at all. Many people because
They are feared that they
fear
might get the pain.
You don't feel the pain after 2 hours maybe. Then I'm home. Then I'm totally
back
okay.
to normal.
Yeah.
So I think we've got a few minutes left, Doc. Very quickly, if you can walk us through. Okay, your practice is predominantly in KPJ hospitals,
Yes.
right? What kind of facilities do you have within KPJ?
Okay, KPJ hospitals, of course, it's a big hospital, and IVF center is inside the KPJ hospital. So in this fertility center, we do provide in IVF. Not only that, we do have PGS. PGS, as I told you, is a pre-genetic screening, where subsequently after the IVF, we will analyze this embryo or the egg to see whether this is a good quality of embryo. That means screen them from the syndromic baby. All right. Not only that, we have these facilities, what we call it assisted hatching, where we will hatch the embryo so that the implantation process will be much more easier and better. Not only that, we have a time lapse. Time lapse is where we monitor the embryo in the system, so that we can observe where there's a monitor where we can observe this baby growing. For 24 hours or 48 hours, it can be grow. We need not come middle of the night to check whether it is growing or not. So there's a machine where we call it time lapse. They will monitor. So the next day we need to come and see whether they are growing or not.
Right.
Yeah. So
all these facilities are within KPJ Damansara,
Yeah.
Yeah. So having said that, now the first successful birth of a child after IVF was in 1978.
Yeah.
Now the question is, are there any risks linked to reproductive technologies now?
Okay, risk, I don't think so. If you see naturally when the women they conceive, the risk is there, 2 to 3%. Because as you know, as age advance, there's a risk of conceiving a syndromic baby. But by doing so, this IVF, the risk just increased to 3 to 4%, which is only 1% higher. So is this risk due to the IVF? Is still debatable, or is it due to the age factor?
Very, very interesting indeed. Now coming back to you, Darlene, it must be a very exciting time for both you and your husband.
Yep.
Well, and you're talking on national TV. What is your message to everyone else about IVF or about having a child?
Okay, so to married couple out there who doesn't have baby yet, no matter how long you've been married, like me, I'm 11 years this year. So just put away, don't be shy to ask doctor our problem. I was in your shoes then.
What about talking to your husband? Saying if you have a problem and you need to talk to your husband about it. What would your advice be with regards to having a couple discussion?
Okay, definitely. If couple they talk to their partner,
Husband not to be egoistic, that's the only thing. You need to come
me,
for
I
treatment.
think as a woman, and I read about this, we women, almost 90% of this one is because of from women. It's not from men.
Right.
But it doesn't say that men are safe, no, but it's from us. So don't be shy, nothing, just go and see doctor. It's okay.
Your message very quickly to Malaysia about IVF?
I know there are quite a number of people outside there, they are still not aware of IVF facilities are available. So we do advise to the couple over there, please come forward for the treatment, especially the husband. Sometimes only the wife comes along, not the husband, because most of them, they think the husband, there's no issue or problem with them. But to see you frankly, 20 to 30% the fertility still lies on the husband. Okay, so it is joint both where the couples need to come and seek for the treatment so that we can have a better chance of success of getting pregnancy.
Right. On that note, thank you very much, Dr. Mohan Rajoo, fertility consultant, obstetrician and gynecologist from KPJ Damansara Specialist Hospital. We also like to thank Darlene Ernie, one of his patients, for coming in to also talk about her experience with IVF. Thank you very much. It was a pleasure and an honor to have you on the show. We hope to have you back again, and all the best to you, Darlene.
Thank you so much.
Stay with us right here on Medical Today. We're going to come back with more for you just after a short break. Hello and welcome back to Medical Today, Episode 2, Season 3.0 with me, Jared Rutnam. We now bring you the segment where we talk about first aid mistakes, a little something we're doing on Season 3 on a weekly basis. We'll bring you a video on mistakes with regards to first aid. Now, anytime there's a first aid problem, the first thing you need to remember is to dial 999. I can't impress more as to how important it is for us to be able to do that first in any situation. In the meantime, we've got a little something for you with regards to using butter. Now, some of us, when we have burns or we're scalded, we use butter for it. But are we doing the right thing? Let's take a look at this video and find out about some mistakes with regards to burns or by putting butter on a burn. This video is for you. Let's take a look at it.
The mistake of putting butter on a burn. You've probably heard the tip to put butter on a burn, but this is bad advice. Never put butter on a burn or pop any blisters that form. You could damage the skin and cause an infection. Any greasy substance on a burn keeps the heat in. This could make it hard for a burn to heal or be properly treated. So what to do? Well, place the burned area under running cool water for at least 5 minutes to reduce swelling. Then gently dry the area and keep it loosely covered. You can apply an antiseptic spray or ointment or aloe to soothe the area. If it starts to blister, changes color, or seems infected, get medical treatment immediately.
So I guess you know better now with regards to what you should do when there's an emergency or there's a first aid problem within your house, especially with burns in the kitchen. We go through this all the time, especially for those of us who like cooking or who are cooking for our families. We're always riddled with burns all the time and we sort of do the wrong thing. Now that video, I hope, shed some light on what one should do in a time of emergency or when one is faced by a burn. Well, of course, we did receive some emails from you. Thank you very much for those of you who've sent in emails last week. I would like to tell you that we will announce the winners next week. On that note, this week what we want to do is for you to share your thoughts on IVF in 2 paragraphs, okay? So we talked a lot about IVF today, but we want for you to share your thoughts in 2 paragraphs and send it to ask@medicaltoday.my. That's ask@medicaltoday.my. 2 paragraphs on IVF, your thoughts on IVF. Send it in to us. We're looking for 2 winners. The first prize winner will receive 100 ringgit and the second place or second prize winner will receive 50 ringgit. So please send it in to ask@medicaltoday.my. And if you do have any doubts or inquiries or you would like for us to, of course, feature a certain doctor, please do send us an email. Send it to, once again, ask@medicaltoday.my. On that note, Don't forget, next week we've got two amazing doctors coming on. We'll be having Dr. Aminuddin Rahman Muhammad Maidin and Dr. Azura Daniel from KPJ Specialist Center. Our topic next week is cancer care, management and weak immune systems. All that and more coming your way on next week's edition of Medical Today. I'm Jared Ratnam signing off. You have a great day ahead and a fantastic week. Bye-bye.